Good evening, everybody. Welcome to this special episode of Pursue 7F. And we are streaming live from Coimbatore via Kolkata. And today we have a very special person and a very special topic. We have Dr. Balan Louis Gaspar with us, and he is going to speak on approach to muscle biopsies, technical and tangible, both the pre-analytical as well as the analytical. But before I go, let me just introduce Dr. Balan. He is the founder and director of NextGenPath Diagnostics. He has a distinguished reputation of being the first in the country to super specialize in the field of histopathology. That is, he was the first DM in the country from PGI Chandigarh. He also established the neuromuscular department in the Department of Histopathology in PGI during his 3 years DM residency. He was awarded the prestigious Professor Subhas Kumari Gupta Memorial Gold Medal in post-graduation MD pathology. He has got more than 35 scientific papers in peer-reviewed national and international journals. And he has got a recent book, Myopathology, which is absolute, you can say, a Bible for people who would like to study myopathology. A wonderful book on practical clinico-pathological approach to skeletal muscle biopsies. And Dr. Balan has been a regular invitee in various national and international conferences. He is an expert in muscular neuropathology. And before I ask him to start, let me request all of you to please keep your mic muted. Please keep your camera off. Please don't share your screen. When you join, please press join now and don't press present now. With this, let me request Dr. Balan sir, please share your screen and start your talk. Thank you so much.
Thank you, sir. Thank you for the nice introduction.
Please press present now. Your entire screen and share now. Yeah, I can see your screen coming. Yeah, please make it full screen. Yeah. Yes, sir. Please start. Thank you so much.
Thank you for the nice introduction, sir. Before I go into the main presentation, I would like to put the following disclaimers that this presentation is solely meant for teaching purpose, and the data has been compiled from my own experience, known textbooks, and from authors who I have duly acknowledged them. There are no disclosure regarding financial interest or conflict of interest or any other sorts. I would like to acknowledge at this point of time Dr. Naveen, who had taken a major effort in coming with this series, so that his main motto is to spread the knowledge throughout the country, and also since this being telecasted on the YouTube also, so many people around the world will get benefited. And at this juncture, I would like to thank my mentors, Dr. R.K. Vashish. He is retired professor of from the Department of Histopathology, PGIMER, Chandigarh, and my co-guide, Dr. B.D. Radhra, who is now the current professor and head of Department of Histopathology. Both are neuropathologists and had been instrumental in providing me the guidance throughout my tenure in PGI. And I would also like to thank all the neurologists who have constantly trusted and provided me the opportunity to interpret the muscle biopsies for their patients. Coming to the introduction, the word muscle is derived from the Latin word musculus, which means a little mouse. Skeletal muscle constitutes approximately 30 to 40% of the total body mass. In an average adult and in an average neonate, it's approximately around 25%. Whenever we interpret a skeletal muscle biopsy, we need to know the following factors before we see a biopsy. What is the genetic makeup of the individual? His physical activity, for example, if he's an exerciser, regular exerciser. Nutrition, for example, whether the patient is malnourished or not, or the patient is on any hormones, and are there any other comorbidities? Because these factors influence your interpretation of muscle biopsy. So before going into the processing of muscle, we need to know about the basic anatomy of the muscle. As you can see, muscle is attached to the bone by means of a tendon, and the surface of the bone is covered by periosteum, and the tendon sheath, which is also continuous with the periosteum. This tendon, at one point of time, gets attached to the muscle. Here you can see. So this is the myotendinous junction. So the same connective tissue fascia will cover the entire muscle, and this connective tissue fascia is called as the epimysium. This epimysium then splits and divides the fascicles. So this dividing connective tissue from the epimysium is called as the perimysium, and from the perimysium, tiny connective tissue slings go and surround the individual myofibers, and this connective tissue is called as endomysium. So this is the higher view of the individual muscle fibers. See, this connective tissue, as you can see, is the endomysium, and these are the individual myofibers surrounded by the connective tissue, endomysium. And each myofiber or the muscle fiber, they contain nuclei which will be present at the periphery. Here you can see, and they will be surrounded by the satellite cells. So satellite cells regenerate whenever there is injury to the muscle fibers. The cytoplasmic contents, basically like any other cell, they are rich in cell organelles, of which mitochondria is the richest source. In addition, there are myofibrils. Okay, so the myofibrils play a main role in muscle contraction. So, what are the indications for muscle biopsy testing? There has been a decline in the muscle biopsy testing in the recent past because for the following reasons. There have been many non-invasive diagnostic modalities. Counseling the patient is a bit difficult. Technical factors are involved because everyone is not expert in doing muscle biopsies, and there are availability of experts involved in performing and interpreting the muscle biopsies. So there are there is a role for muscle biopsy because whenever the non-invasive modalities have failed or they have become non-contributory, there is a major role for muscle biopsy. And why they primarily need to do a muscle biopsy in such instances is they want to distinguish whether the disease is treatable or not treatable. If it is a not treatable one, whether the disease will progress or whether the disease will be static. However, there are a lot of implications. For example, prognostic implication. If you can see, you make a diagnosis of muscular dystrophy in a young child. So prognostically, it portends a very bad prognosis. And in some instances, there can be major, for example, in case of inflammatory myopathies or a dystrophy being misdiagnosed as an inflammatory myopathy, you can prevent or you can prevent the over or under treatment. For example, for a dystrophy, you don't need to give steroids. Whereas in inflammatory myopathy, if you are not picking up an inflammatory myopathy, the patient will not get steroids. So that makes a major role. In medical conditions, for example, a patient will just present with a for example, CVA or a myocardial infarction. Patient will be receiving statins. So statins will produce myopathy. That can be of two types, which I will be discussing later in due course case discussions. Surgically, for example, a patient may just present with a hernia and he may have an underlying myopathy which may not be known. Most important is the anesthetic complication because some of these patients may end up in developing malignant hyperthermia, a condition called central core myopathy, which produces malignant hyperthermia. These patients have mutations in ryanodine receptor genes. So again, there are family implications. For example, depending upon the inheritance, the family would like to know whether the next pregnancy they will have an affected child or a non-affected child. So that plays an important role. Occupationally, for example, some diseases, for example, mitochondrial myopathies, they affect the vision. So the patient's occupation may be involving the eyes, for example, like a pathologist or a or a pilot or a driver, their main tool is their eye. So once you have an affected eye, it's very difficult for both the person as well as the people surrounding them. It puts the others in risks. And social, for example, certain myopathies they are, for example, the surrounding people, they don't welcome these people. For example, if there is a person who is not doing well because of the myopathy, there may be social issues, and he may not be able to mingle with everyone. So, however, there are certain myopathies that can only be diagnosed on biopsy. So, a best example is congenital myopathy with fiber type disproportion. As the name suggests, the diagnosis can only be made by muscle biopsy. So, these are the various implications for muscle biopsy. When planning a muscle biopsy, it starts at the clinic. So, arbitrarily, you need to look at the disease under question. You need to determine what size is needed for the biopsy and from which site the biopsy has to be taken. So, as a general rule, avoid biopsies from site which are subjected to any form of physical trauma. I will be discussing later in the next slide. So, in our protocol, what I usually prefer, I ask for a fresh, which means unfixed, not in formalin. So, this is the most important thing I need to tell you. Muscle biopsy should not be interpreted in formalin. Okay, and the biopsy should be 2 into 2, approximately 2 into 2 centimeter size. The size can be a bit less in infants or child, where the size can range from 0.5 to 1 centimeter. And when the disease is known, you can choose the power of the muscle. When the disease is not known, it is better to take a biopsy from a moderately affected muscle. And once the muscle is taken out, the muscle should be wrapped in slightly moistened gauze piece or a cling film, and then wrapped in a closed ice pack container and transported as quickly as possible. Preferably, I ask them to transport within an hour. So, what are the selection criteria for muscle biopsy? In a chronic disease, for example, a dystrophy, it's always better to take a moderately affected muscle. The disease is known. For example, why? The severely affected muscle, you are going to see only fat and fibrosis in the light microscopy. So, there is no use. If you are choosing the mildly affected muscle, you are not going to see the dystrophic features. Right? So, it's always better for a chronic disease to choose a muscle which is moderately affected, that is a power of 3 by 5. Okay, MRC. If it is an acute disease, it's always better to choose a severely affected muscle. For example, an inflammatory myopathy, polymyositis, where the maximum findings you will get in a severely affected muscle. And best specific sites for muscle are quadriceps, deltoid, and biceps. And the most important thing, you have to ask the treating physician or the person who has taken the biopsy as which site of the body the biopsy is taken, because it's very important to orient the muscle before processing. MRI can be useful to select pathological sites in difficult cases, but however, it's not done very regularly. And when I told avoiding the sites which are of previous trauma, most important sites are injection sites. For example, whenever a patient is admitted in hospital, the first thing they give us a gluteal injection. So they should not prefer those kind of traumatic sites. And most of the myopathies will have undergone a needle EMG. So whenever there is a needle EMG, try to avoid those muscles because they will give you an artifactual change while you are interpreting a muscle biopsy. So why this anatomical classification is important? As you can see, depending upon the fibers, the muscle types have been divided into various types. For example, multipennate, they have multiple separate fascicles, and muscle, for example, a biceps brachii has two sides tendon and one side belly, and always you ask them to take the biopsy from the belly side. So myotendinous junction will give you false artifactual changes. So these are the things important whenever you are looking at the biopsy, because or when the clinician is asking you where to take the biopsy from, what are the sites you have to avoid. So you have to be very clear. If you are telling, if he is persistent to take from a biceps brachii, tell him that both ends will have tendons, so you have to take it from the center. Right? And whereas in rectus, the central one will be the tendon. Okay, on either side you will be getting the fibers. So you have to choose only either sides. So that is the most important thing you have to tell the clinician when they are going to take the biopsy. So when a biopsy is taken outside, you can see the fibers grossly. That these are the fibers which are running lengthwise. You divide the biopsy into three, and the largest portion you keep it for routine stains, HND, special stains, enzyme histochemistry, and immunohistochemical studies. The smallest portion you keep for ultrastructural studies, and the intermediate size portion you keep it for biochemical studies and molecular studies. Because EM needs only a small tissue, and in very rare cases you will be doing EM. Whereas routine special enzyme and immunohistochemical studies are the most important things, without which you may not get a diagnostic lead. Now I move on to the processing. As I told, there is negligible, almost no role for formalin fixation in muscle biopsies. All muscle biopsies should be snap frozen, for which the muscle biopsies are transversely oriented. Once the biopsies are oriented, then you take a container or a glass vial, fill the glass vial with isopentane, then immerse the isopentane in liquid nitrogen so that the isopentane first freezes. So once the isopentane freezes, then deliver the muscle inside the isopentane so that the muscle freezes in the isopentane. Then once the muscle is frozen inside the isopentane, then the muscle is again oriented inside the cryostat and transverse sections are taken. So when transverse sections are taken, the thickness is also important, because for routine histochemistry special stains, a thickness of 7 to 9 microns is preferred, whereas for immunohistochemistry and immunofluorescence, a thickness of 3 to 4 microns is preferred. And once the procedure is complete and you are left over with muscle, the leftover muscle can be covered in silver foil and stored at minus 80 degrees Celsius, which can be used for future studies if necessary. Now coming to the histology. This is a well-oriented muscle which has the components which I previously discussed in the anatomy. So it starts with the epimysium. Epimysium is nothing but a connective tissue which comprises of fibrous tissue and fatty tissue. From the epimysium, slings of connective tissue go separate the individual fascicles, and from the individual fascicles, small connective tissue runs and surrounds the individual muscle fibers. So the outermost connective tissue is the epimysium. From the epimysium goes the perimysium. From the perimysium goes the endomysium. This is the higher power view which I am showing. These small spaces are nothing but the endomysial spaces, and these dark things are nothing but nuclei. And the nuclei of muscle and skeletal muscle are always noted at the periphery. Whenever there is centralization or internalization of nuclei, it is abnormal, and that abnormality we have to correlate with a certain percentage of the muscle fibers. Depending upon that, you can arrive at a working diagnosis. And in the endomysium, perimysium, and epimysium, you will have blood vessels, nerves, which will be supplying the fibers. Right? These are again normal structures. This is a muscle spindle, and this is the intramuscular nerve quick. So don't get confused with abnormal things. This stain is called as modified Gomori trichome. Very important stain in the diagnosis of muscle biopsies, which I will be discussing in the coming slides. As you can see, the connective tissue is stained bright green. Fatty tissue is not stained. These are the nerves, intramuscular nerves, and this is the myelin is appearing reddish, right? And central axon is appearing green. The other abnormal things I will be discussing here. So this is a normal intramuscular nerve, and this normal intramuscular nerve, if you are lucky enough to get in the biopsy, is the internal control for your biopsy. And if you are not able to get it, you have to run a control along with your muscle. So coming to enzyme histochemistry, for all practical purposes, the fiber types fall into two broad categories: slow or type 1, and fast or type 2. So if you remember one, you need not remember the other. So it is always a confusion. So remember one. Slow is type 1. So fast will be type 2. And the type 2 fibers are further subclassified into 2A, 2B, and 2X based on the histochemistry special stains and immunohistochemistry. So there are also immunohistochemistry available to subtype the fibers, and it's not required in all cases. Type 1 and type 2 fibers predominantly utilize the oxidative pathway, whereas type 2X and type 2B fibers utilize the glycolytic pathway. As I told, developmental myosin isoforms can be expressed normally during the antenatal period, and they can be observed in postnatal life under certain pathological conditions. So, in regenerative fibers, whenever there is a fiber which is degenerated and it is going to regenerate, the regenerative fibers will usually express the neonatal or the fetal forms of myosin. So, that will be helpful to know that this fiber is regenerating. In addition, one muscle fiber can express more than one type of myosin heavy chains, and in such type, the fiber is called as a hybrid fiber. This is NADH-TR. NADH-TR is an oxidative enzyme stain. It stains both the myofibrils as well as the mitochondria. So it's a broad stain. The fibers which are appearing dark are the type 1 fibers or the slow fibers, whereas the fibers which are appearing pale are the type 2 fibers or the fast fibers. So this is the normal checkerboard pattern of a muscle in an NADH stain. So if you ask me which is the most important stain, I will say it's HND stain, because just visualize this picture. This is a individual muscle fiber, and there are some bluish structures within the cytoplasm, and there are pale areas. So these bluish structures constitute the mitochondria and the myofibrils, mainly the mitochondria, and the pale area doesn't contain any mitochondria. This is the NADH stain, as I told. It stains both the myofibrils and the mitochondria, and the pale areas are not taken up by the NADH stain. SDHS, succinate dehydrogenase stain, is also an oxidative enzyme stain, but it is specific for mitochondria because succinate dehydrogenase is nothing but complex 2 of mitochondria. So whenever you want to distinguish whether this darkly stained fibers are due to the mitochondria or only the myofibrils, succinate dehydrogenase stain will help. So the central areas are devoid of mitochondria. The peripheral, there is peripheral condensation of the mitochondria. This is an abnormal case. This is not a normal case. Similarly, there is one important stain called as a double stain, cytochrome oxidase and succinate dehydrogenase double stain. Whenever you want to highlight a fiber which is deficient in cytochrome oxidase. Cytochrome oxidase is nothing but complex 4 of the mitochondria. So this fiber takes up the blue, which is succinate dehydrogenase, whereas this fiber has both blue and brown. So this is appearing dark brown. So you can very well and clearly tell that this fiber is deficient or negative for cytochrome oxidase. So this is a very important stain, and I will be discussing later why. Coming to the immunohistochemistry, the utility of immunohistochemistry and immunoblotting in diagnostic muscle pathology is very important. There are diseases that arise due to defective proteins, defects in the sarcolemma, defects in the sarcolemmal region, sarcoplasm, mitochondria, nuclear membrane, extracellular matrix, and so on. And there are also important markers of inflammatory myopathy, which I will be highlighting about, because that is most important. You need to distinguish a case whether it is an inflammatory myopathy, it is a non-inflammatory myopathy. If it is a non-inflammatory myopathy, it is a dystrophy, or it is a metabolic myopathy, it is a mitochondrial myopathy, or neurogenic. So most important thing is inflammatory, because inflammatory myopathies are treatable myopathies. So while emphasizing the inflammatory myopathy, this is a case of an inflammatory myopathy, and this is an immunostain called as MHC, major histocompatibility complex 1, which should not normally expressed by a muscle fiber, sarcolemmal location. So whereas in this case, there is strong sarcolemmal expression of MHC class 1. The internal control will be the endomysial capillaries. So endomysial capillaries will normally express MHC class 1. So that is how you know that the stain is working. So this is a case of an inflammatory myopathy with upregulated MHC class 1. C5b9 is nothing but, you have read the complement pathway, and the final product of the complement pathway is C5b9, or otherwise called as membrane attack complex. Membrane attack complex normally gets sequestered in the perimysial blood vessels. Okay, so this is a normal control. Whereas whenever you find it in the endomysial capillaries, it is abnormal. So this is a normal case, right? So coming to the classification, how do we classify the myopathies? This is the broad classification, which is practically useful. You categorize the myopathies into dystrophies, inflammatory myopathies, mitochondrial myopathies and related diseases, congenital myopathies, metabolic myopathies, myopathies of miscellaneous etiology when you are not able to put these under any particular category. Diseases of neuromuscular junction I have not highlighted because these are rarely biopsied, except very few conditions which are not necessary for discussion. And neurogenic disorders. Right. So coming to muscular dystrophies. So muscular dystrophies are a heterogeneous group of genetic disorders that have in common progressive, irreversible loss of muscle fibers and that result from repetitive cycles of degeneration, necrosis, regeneration, and eventually there is fat and fibrosis, which replaces the muscle fibers. So this is a very important diagram where important components of the muscle fibers are labeled here. Whenever we look at a muscle fiber, as I told, this is the sarcolemma. There are sarcolemmal associated proteins. There is extracellular matrix which connect the sarcolemmal proteins to the extracellular matrix like lamin alpha 2. And there are molecules which connect the subsarcolemmal proteins with the sarcoplasmic proteins, for example. So all are interrelated, and whenever there is a mutation of one particular protein, they will lead to the defect or dysfunction of the muscle fiber. So that is how it works. So for basic understanding, the mutations can be in the plasma membrane proteins like dystrophinopathies, which are Duchenne muscular dystrophy, Becker's muscular dystrophy, or it can be in the sarcoglycanopathies, which can be defect in the sarcoglycans. So there are 4 sarcoglycans: alpha, beta, gamma, and delta sarcoglycans. Okay. Similarly, there can be problem in the defective basement membrane or the extracellular matrix, as I told previously, or there can be problem in the sarcomere or Z bands, where the disease is called as telethoninopathy. The protein is teletonin. Or there can be problem in the nuclear membrane proteins or nuclear matrix proteins, also called as laminopathies. There can be defects in the enzymes involved in the post-translational modification of key structural proteins like alpha dystroglycan. Or there can be alteration in the vesicular trafficking like caveolin. Caveolin, everyone knows that it is present in cells. And the problem whenever there is a mutation in caveolin protein, that it can give rise to a dystrophy called as caveolinopathy. And lastly, there can be also the defects in key enzymes like calpain. Calpain is a key enzyme, okay, for sarcoplasm. So this is a muscular dystrophy. This is how it looks like. I have already showed you the normal muscle. Here you can see mainly there are fat, there is fibrous tissue, and the architecture is completely effaced, and the fibers have become round and they are well separated by fibrous connective tissue. You are not able to distinguish between perimysium, epimysium, endomysium. So this is fascicular effacement. You do a connective tissue stain. This is a acid fusion orangey stain. You can find that the fibrous part is completely blue. The muscle fibers appear orangish yellow, and the fat appears unstained. So this is a clear-cut case of muscular dystrophy. So once you know that you are dealing with a muscular dystrophy, you do a panel of immunostains. Depending upon the age and sex, you can select which particular panel you need to choose. These two panels, for example, dystrophin 1, 2, 3, emirin, myrosin, collagen 6, and alpha dystroglycan, sarcoglycan alpha, beta, gamma, delta, dystrophin 1, 2, beta dystroglycan, and caveolin, that they can be done by immunohistochemistry. Whereas for calpain, you cannot do it in the sections. So you have to extract the protein from the muscle. You have to run a Western blot, and in the Western blot you have to do the immunostain. So it is called as immunoblot. So whenever there is a complete absence of all the 3 dystrophins, usually the patient is labeled as Duchenne muscular dystrophy. Presence of at least one dystrophin will make the diagnosis of Becker's muscular dystrophy. And isolated fibers with complete loss or complete absence of staining are DMD carriers. DMD carriers are usually females. And absence of emirin indicates an emery muscular dystrophy. So this is a basic overview, and this is not a hard and fast rule. Coming to the next category of myopathies are the inflammatory myopathies. So inflammatory myopathies are a group of acquired muscle diseases. They occur in a myriad of clinical settings, whereas they have a common denominator, that is, they present that moderate to severe muscle weakness, and there are features of inflammatory myopathy on muscle biopsy. And when I mean features of inflammatory myopathy on muscle biopsy, it's not necessarily that there should be inflammation, because even in the absence of inflammatory infiltrate, presence of MHC class 1 or class 2 on the sarcolemma will make it an inflammatory myopathy. There are exceptions to this particular rule. For example, there is a dystrophy called as dysferlinopathy, which has upregulation of MHC class 1 in the biopsy, sarcolemma, right? So it's not that is one condition. So whenever you are interpreting, you have to interpret in the whole context, not only with presence of inflammation or just the presence of MHC class 1. Similarly, complement activated inflammatory myopathies, they tend to exhibit markers of complement mediated damage, which are C5b9. Sometimes C5b9 can be substituted for C4b. So C4b is a versatile marker. It can be used in renal pathology, it can be used in myopathology. So it's a versatile marker. And as I told in the previous discussion, endothelial surface endomysial capillaries and sarcolemma of the affected muscle fibers show positivity in these type of inflammatory myopathies. So basically, the inflammatory myopathies are divided into group 1, group 2, group 3, group 4, and group 5. Group 1 will be sporadic inclusion body myositis. Group 2 is polymyositis. Group 3 is dermatomyositis. So previously it was just called dermatomyositis. Now dermatomyositis has been subdivided into the following categories. That is MDA5 associated dermatomyositis, MI2 associated, TAF1 gamma associated, NXP2 associated, and SAE associated. Okay. And whenever you are not able to categorize, you put the category under non-specific myositis. The most important group is immune-mediated necrotizing myopathy, because they present with a fulminant form of inflammatory myopathy, and the main pathological feature is myonecrosis. Okay. So they can be associated with SRP antibodies, or they can be associated with anti-HMG CR, that is anti-HMG CoA reductase associated, or there is a subtype called as necrotizing myopathy with pipe stem capillaries, or it can be associated with paraneoplastic phenomenon. So I want to highlight this particular entity, that is anti-Jo1 or anti-synthetase syndrome associated necrotizing myopathy, because previously perifascicular atrophy was considered to be pathognomonic of dermatomyositis. No, it's not pathognomonic. It can occur in various settings, and one of the most important setting is anti-Jo1 myositis. So why do we need to distinguish? Because these patients also have lung problems. They have interstitial lung disease, and they have a poor prognosis. Whereas dermatomyositis subtypes, they have different clinical connotations. So you need to distinguish dermatomyositis from anti-Jo1 myositis. So I just go through a case so that you will understand the importance of diagnosing an inflammatory myopathy. So a female in her 50s, she had gradually progressive weakness of both the upper limbs, forearm and hand muscles. Lower limbs proximal was more than distal, and severe quadriceps wasting for the past 3 years. In addition, she also had dysphagia and probable tongue fasciculations. Reflexes were normal. Sensory system was intact. There were no cerebellar signs or autonomic dysfunction, and EMG was showing neurogenic pattern. So this was a confusing picture. Whereas NCS, that is nerve conduction study, EMG is electromyography, and NCS is nerve conduction study. So nerve conduction study showed motor axonal neuropathy. So it was a confusing picture. So you see the muscle biopsy, you can see there is a variation in fiber size, but the nuclei are located at the periphery in this fiber, whereas here there is internalization. Whereas this is the most catching feature. Here you can see multiple vacuoles, and the vacuoles contain basophilic granular material. Here you can see the vacuoles are containing basophilic granular material. There is fibrosis and fat infiltration. This is a modified Gomori trichome stain. So these are the purple dots which you are seeing, nothing but the granular basophilic inclusions which we are seeing in the HND section. So this is a case of sporadic inclusion body myositis, a typical presentation that can confuse the clinician because it can show neurogenic features in EMG as well as NCS. So why we chose this particular entities? Although it is an inflammatory myopathy, it behaves like a dystrophy. There is no role for immunosuppression, and there can only be a supportive care because the pathogenesis is not very well known. Some say that it is a degenerative process, and some say that it is an inflammatory myopathy. But since it has been it has been grouped under the inflammatory myopathies, so we are following the same classification. So this is one particular entity which I would like you to remember. So as I told, take-home messages, neurogenic features can be seen in sporadic IBM. Although classified as an inflammatory myopathy, response to immunosuppression is very poor. And whenever you have a biopsy, which is repeatedly reported as polymyositis, then you have to be very cautious because the inclusions can be underrepresented, and it could very well represent a sporadic inclusion by myositis. So I'll discuss another case. A female in her 30s was on atorvastatin and aspirin because she had an MI. So after starting the atorvastatin, she had progressive proximal muscle weakness, pain, upper limbs more than lower limbs, and facial atrophy. And the weakness was progressive, and she was bedridden. Reflexes were normal. It was suspected a statin myopathy because atorvastatin can cause statin myopathy. So she was stopped statin, but she had no improvement. Whereas the CPK was showing marked elevation despite stopping the statin. So that is why biopsy was done. Whereas here you can see dense inflammation, regenerative and degenerative changes, myocyte necrosis. The connective tissue, perimysium, is markedly widened and shows edema, inflammatory cells, and it is degenerated. It is fragmented. So MHC class 1 diffuse upregulation in all the myofibers, indicating that this is an inflammatory myopathy rather than a statin myopathy. And you can see that the inflammatory cells will also express MHC class 1. C5b9 I told. So it's a terminal complement pathway. It stains the membrane attack complex of the incipient myocyte necrotic fibers. Okay. So this is an immune-mediated necrotizing myopathy, probably anti-HMG-CoA. That is because statins are directed against the HMG-CoA receptor. Right. So this is an inflammatory myopathy related to statins, not the routine statin myopathy. So what was done? Apart from stopping the statins, the patient was also started on steroids. And follow 3 months, the patient started walking with support, and following 6 months, the patient started walking without support. It makes a huge difference for the patient. So what is the pathogenesis? Is whenever the patients are exposed to statins, there is a degeneration of the myofibers, and that releases HMG-CoA into the circulation. The HMG-CoA gets exposed, and antibodies develop against HMG-CoA, and this gives a repeated cycle of inflammatory, degenerative, and regenerative change. That is why the patients present with pain and so on, despite stopping the statins. So this has to be diagnosed. Otherwise, it's very difficult. Coming to the next group of myopathies, metabolic myopathies. Metabolic myopathies refer to a set of muscle disorders caused by impairment in the catabolism of substrates to produce ATP via oxidative phosphorylation. So they can be broadly categorized into glycogen storage diseases, fatty acid oxidation defects, and mitochondrial disorders. So mitochondrial disorders are separate group. So I'll be discussing first metabolic and then mitochondrial. So to make us understand, I'll again go with a case scenario. A young female toddler. She had no family history. There was the only symptom being pain in the proximal and distal muscle for the past 6 months. The pain was increasing during physical activity of squatting. Serum CK was elevated and lactate was normal. Usually in mitochondrial myopathies, lactate will also be elevated. And TMS tandem mass spectrometry was not done because the patient was not affordable, hence biopsy. This is an oil redo stain. Here you can see that prominent lipids which are being stained by oil redo stain. So usually these muscle fibers will appear flocculent, and when you do a oil redo stain, there is excess of lipids in the muscle fibers. So this is nothing but a lipid storage myopathy. So the patient was given a cocktail of carnitine, coenzyme 10, and riboflavin, and this patient has to be followed up, and why I took this case under metabolic myopathy is lipid storage myopathies are usually, although they are inherited or genetic myopathies, they respond well. They are treatable myopathies. Okay. And muscle biopsy is very helpful. And in some of the cases, for example, carnitine deficiency, the response to treatment is excellent. In fact, coming to the other case, a male in his 20s, no contributory family history, was symptomatic for approximately 3 years with 3 episodes. The first episode started with severe intractable headache. Occipital lobe showed seizures. There were visual hallucinations, and MRI P2 flare sequence showed multiple hyperintensities over occipital lobes with the involvement of the cortical gray matter. So the current episode, the patient had non-convulsive status epilepticus for the past 1 week. When the serum and the CSF lactate was done, it was found to be elevated. Basic mitochondrial myopathy panel was reported as no mutations found, because this is a basic panel and most of the basic panel will cover only the common mutations. So it is very likely that the panel can be negative, and a negative panel doesn't mean that the patient doesn't have a mitochondrial myopathy, because in this particular case the muscle bags showed ragged red fibers. These are the ragged red fibers. This is the modified bovary trichome. Rest of the fibers are appearing green. The periphery of the this particular affected fiber shows ragged red appearance. So this is a ragged red fiber in a mitochondrial myopathy. And this is a double stain, cytochrome oxidase stage. As you can see, this fiber is appearing blue. These fibers are appearing dark brown because this fiber is deficient in COX. So coming coupled with the clinical history and the muscle biopsy finding, this is a mitochondrial myopathy with a ragged red fiber, MELAS, mitochondrial encephalopathy with lactic acidosis syndrome. Okay. So what has been done? This patient was counseled and was given supportive care. At follow-up, he was static, but usually MELAS patients have a different prognosis depending upon how many mitochondria are affected, because there is a phenomenon called as mitochondrial heteroplasmy. If you are interested, you can go and read. So take-home messages, it has occupational implications. As I told, if this patient is a driver or if the patient is swimming, when the patient gets a seizure, it's very difficult. And usually in seizures, valproic acid, phenytoin and barbiturates are drugs which are given, whereas these drugs should be avoided in mitochondrial myopathy. So if you give these medications, these patients are going to get seizures. So that is why it's very important to diagnose mitochondrial myopathy, right? And there are other drugs like propofol. These are anesthetics. So whenever this patient ends up in a surgery or needs an anesthesia, the information that this patient has a mitochondrial myopathy plays a very vital role for the anesthetist. And genetic test can be misleading where muscle histochemistry can be helpful in picking up the diagnosis. Okay. So then we move on to the next group of diseases called as congenital myopathies. So congenital myopathies are a gamut of clinico-pathologically and genetically distinct disorders. They are characterized by early onset hypotonia, muscle weakness, and inherited in autosomal dominant, recessive, or X-linked manner. The key here is usually they have respiratory muscle weakness, often most severe, and this is out of proportion to the limb muscle weakness, unlike the limb girdle muscular dystrophies. And the pathological abnormalities common to most of the congenital myopathy is the presence of hypotrophic type 1 fibers. So type 1 fiber hypotrophy is the key feature. This is one case of congenital myopathy with fiber type disproportion. As I told, type 1 fibers are darkly stained fibers and type 2 fibers are lightly stained fibers. Here you can see the type 1 fibers are atrophic, whereas type 2 fibers are normal or hypotrophic fibers. So this type 1 hypotrophy is a feature of congenital myopathy. In the absence of other features to look for, this can be labeled as a congenital myopathy with fiber type disproportion. So this disproportionate type 1 fibers are more and they are hypotrophy. So this is one example. A male toddler had insignificant antenatal and perinatal history, delayed motor milestones, generalized hypotonia, calf hypertrophy and gait abnormalities. Deep tendon reflexes were normal, creatinine kinase was normal, MRI brain was normal, and metabolic workup was negative. So since this child had a calf hypertrophy, it was suspected to be a Duchenne muscular dystrophy, and mutation testing for 79 exons by multiplex ligase polymerase amplification. There is MLPA was negative. So biopsy was done because this was non-contributory. And this NADH stain, what this NADH stain is showing is you are seeing central oxidative enzyme deficient areas, which are called as central core. These are cores, central cores. And this myopathy also produces a specific finding in this stain called as phosphotungstic acid eosin. You can also use phosphotungstic acid, hematoxylin. And the core-like areas which you saw here in the oxidative enzyme stains are darkly stained here. So this is a case of central core disease, and this patient was advised rhinorin receptor mutation because these patients are at risk of malignant hyperthermia. So the child can at any point of time land up in surgery or any form of anesthesia where they have to be cautious in giving general anesthesia because rhinorin receptor mutations are prone for malignant hyperthermia. And as I told, calf hypertrophy is not pathology of Duchenne or Becker's. It can be seen in even congenital myopathies. A high index of clinical suspicion is required to evaluate these cases further. So that is why biopsy was done. And muscle biopsy is diagnostic and it helps to guide further genetic testing. So because we are seeing central cores, we have advised rhinorin receptor mutation in this particular case. So that is why biopsy has helped this particular child. Coming to neurogenic disorders. So neurogenic disorders are characterized by myopathological features which are secondary to denervation. And these include spinal muscular atrophy, spinal and bulbar muscular atrophy, amyotrophic lateral sclerosis, and chronic acquired neuropathies. The muscle biopsy may show evidence of reinnervation and compensation, which I demonstrate in the further slides. And this reinnervation frequently disrupts the normal checkerboard pattern. So in the first slide, I showed you the checkerboard pattern. Equal distribution of type 1, type 2 fibers, giving a checkerboard appearance. This eventually leads to sharing of the same muscle fiber type, the so-called fiber. So this is a case of spinal muscular atrophy. This particular fascicle shows markedly hypertrophic fibers and very, very atrophic fascicles. This is a complete fascicle which is atrophic. This is a fascicle, this is a fascicle. So there is a group or a fascicular atrophy, and the same fascicular atrophy is demonstrated in NADH stain. So this is the fiber type grouping. So when you are not able to group the myopathies under any particular category, you just put under a category called as miscellaneous. And there are certain diseases which can be classified as genetic or non-genetic. In the genetic diseases are the myotonic dystrophies, facioscapulohumeral dystrophy, oculopharyngeal muscular dystrophy. Why I have included these under the mysterious entities? Because their pathogenesis is completely different. I don't want to include them in the dystrophies. Myofibrillar myopathies, because they have particular myofibrillar architectural disruption. So the architectural disruption can be due to because of desmin mutation, which can be desminopathy, alpha beta crystallinopathy, myotillin is another protein, myotillinopaty. So based upon the protein under defect, they are called as proteinopathies or myofibrillar myopathies. Hereditary inclusion body myositis. This is different from the sporadic inclusion body myositis. Sporadic inclusion body myositis comes under the inflammatory myopathies. And autophagic vascular myopathies. So these are a separate group of myopathies which cannot be particularly categorized. So coming to the case, this is a female in her 20s, had progressive proximal muscle weakness. Upper limb weakness was more than lower limb weakness, had severe wasting for 3 years. The quadriceps was spared. Why this is important? Because in a sporadic inclusion body myositis, it usually affects the quadriceps, whereas in this particular entity, which I will be showing later, the quadriceps will be spared. There is finger flexor weakness. Reflexes were well preserved. Sensory system was intact, and muscle biopsy near back, but it was reported as inflammatory myopathy. The patient was started on rituximab and steroids, and there was no response, and CPK was normal. So I advised for a repeat biopsy. So here you are able to see inclusions again. Inclusions, basophilic rimmed inclusions. There is a necrotic fiber. There is inflammation. There is myophagocytosis and modified Gomori trichrome. At the periphery, you can see that dark fusionophilic granules, which were basophilic on HND stain. The case of hereditary inclusion body myopathy, and management and they have to be counseled because it cannot be treated. This patient on steroids or rituximab. Why this is a case of this is a case where you can avoid steroids and the complications of steroids, avoid rituximab, complication of rituximab, because rituximab is also costly, so there is a cost burden for the patient. There are so many things involved in diagnosis. Right. Follow up after 1 year, this patient remains static without any treatment and just with supportive care. So that is the crux of this presentation. You need to distinguish the entities because they are clinically relevant. So in this particular case, I want to emphasize that hereditary inclusion body myositis can mimic inflammatory myopathies and not muscle biopsies with inflammation or inflammatory myopathies. Markers of inflammatory myopathy like MHC class 1, C5B9 cannot be done on prominent fixed biopsy. So probably in that particular case, it would have been a paraffin section which would have shown inflammation, and it would have been reported as inflammatory myopathy. So that may be the reason why it was called initially as inflammatory myopathy. And it's always better that to make sure that the center which has the facility to process fresh muscle biopsies and has the markers of inflammatory myopathy be preferred, because it makes a huge difference. And treatment response is generally poor in these patients. So if you are very interested in going through muscle biopsies, there are various textbooks. These are the textbooks which I have highlighted. They are all equally good textbooks, and you can go through. Thank you so much. Hello?
Hello?
Yes, sir.
Can you hear me?
Yes, sir. Yes, sir.
Yeah, I can hear you. Actually, just the connection at the last minute it just got lost. So
It's okay, sir.
wonderful presentation, excellent, and it went absolutely flawless. So nice, so good, wonderful. It is going to be a very help for everybody. There was a big crowd there at the YouTube, and everybody must have enjoyed this excellent presentation. And indeed, you are a master in muscle biopsy. And I bet everybody across the entire country, as well as people who are watching across the globe, will definitely benefit from this. Thank you much. Let me see if there are any questions on the YouTube, or if there are any questions here. Is anybody wanting to ask any question to Dr. Balan?
Sir, I think one question is there in the chat from Sunil.
Yeah, no, they have just started putting. Hemachandra says, excellent presentation, Manish Gandhi. How to pick up steroid-induced myopathy on biopsy?
Sir, actually, steroid-induced myopathy, first, we need a history of steroids first. So that is the first step. In biopsy, it's really difficult, but usually you see a lot of regenerating fibers in biopsies treated with myopathies. And usually you see the fibers which will be having a particular group. So I'm not really very sure that we can make a diagnosis of steroid myopathy based only on muscle biopsy alone. So that's my point.
Okay. Dr. Srinivas has a comment. Very well presentation, Dr. Balan. Dr. Srinivas is there on the YouTube, so he has made a comment from there. And just let me wait and see if there is any other question. I think there is none. Thank you, Dr. Balan, for this excellent presentation. Thank you so much. God bless you.
Thank you,
So
sir.
nice of you to take it up. There's one question from Dr. Nabanita Das. How common is thyrotoxic myopathy?
Thyrotoxic myopathy, usually they don't biopsy. Okay. So whenever there is hypothyroid myopathy being biopsied, the indication would be to rule out an inflammatory myopathy. Usually thyroid myopathies are not biopsied because what they first do is they first, if it is a thyrotoxicosis, they will try to control the thyroid levels by giving medications. If it is hypothyroid, they will give thyroxine supplements and they will look at. So despite giving thyroxine supplements, the myopathy progresses or remains static, then they go for a biopsy. And in such cases, usually there will be inflammatory myopathy component. So that is how it usually is. So we have published a case of Hashimoto thyroiditis when I was in PGI. If you want, you can go through the publication. It's available. So that particular patient had hypothyroid, and the patient didn't respond to conventional thyroid supplements. Underwent a biopsy. The biopsy had a endomysial germinal centers, just like you see in thyroid. So we thought it could be inflammatory myopathy like that. So it was like that. And I think Dr. Sunil has a question regarding COX SDH stain again.
Right.
So cytochrome oxidase is a complex 4 of, I can go to the
Yeah.
okay. So I'll share the screen now.
Yeah, you can share the screen.
Okay. Okay. So this is the cytochrome oxidase SDH stain. So this is a double stain. It stains both cytochrome oxidase and succinate dehydrogenase. Right. So usually the normal staining should be this particular color, type 1 fiber, and type 2 fiber should be this particular color because cytochrome oxidase uses DAB. So DAB will be giving a brown color, and this SDH will be giving a blue color because it uses NBT, nitroblue tetrasodium. So blue and light brown will give you a dark brown. Here, whenever the fiber is deficient in cytochrome oxidase, it will not show any brown, so it will appear only blue. So this fiber is a deficient fiber, so this is an abnormal staining. It's not a normal staining. I think you got the point, right?
Right. There is another question by Dr. Hemachandran.
Yes, sir.
He says, presentation of nemaline rod myopathy. Any information?
Sir, nemaline rod myopathy is a congenital myopathy. Actually, I have the pictures, but since I just wanted to take a prototype of one particular disease, I didn't put. Nemaline rod myopathies will usually be picked up in modified Gomori trichrome. They will stain red in modified Gomori trichrome. And when you do an electron microscopy, you will find dark rod-like structures usually located at the Z bands. So that is very typical. And you can do a genetic studies for confirmation. And nemaline rods can be present in other forms of congenital myopathies also because congenital myopathies can have overlapping features.
Right. Any other question? Dr. Nabalita Das, would you like to unmute and ask a question directly? No, she says no. Let's just wait for a minute to see if Dr. Hemachandra has any other thing in the YouTube. Is because it takes a time lag for the YouTube data to go. Right. So there is no questions there. Everybody is saying wonderful presentation. So thank you, Dr. Balan, for this excellent, wonderful presentation.
Thank you.
And this will be there in the YouTube, and so that overnight people from the Far East as well as from the Europe will be able to see that, and we will be getting more comments. If there is anything, I'll put it up for you. You can answer that on the Telegram group. Thank you so much for consenting to give this lecture. Thank you. God bless you. Take care. Good night. Bye-bye.
So thank you so much. Thank you. Yeah.